friend, colleague, and collaborator. I have known and worked with Ron for 14 plus years. So, you know, I just, you know, I've had a really great purview to see all the amazing work that he has done. Ron is a full professor at Thomas Jefferson University in the Sidney Kimmel Cancer Center. He is the director of population health there. And, you know, I'm not going to sort of read his CV, but it's one of those ones that you can measure, you know, in inches rather than pages or lines. So he's, you know, been consistently successful in terms of, you know, disseminating his work through publication and sustaining his work through funding. And all of that work, I think you could say is fair, has come into the world of cancer screening, cancer prevention, a lot of focus on shared decision making. And he's going to talk to us today about the RCaDES Initiative. So I'll leave that part to him. Although I would say that learning community that he has established is something that we probably want to emulate here. And I'll just give a personal thing, you know, in working with the cancer screening, I have always been very appreciative of Ron sort of making me remember who is left out, you know, who are the vulnerable populations that maybe even when the rate is reaching 80%, who's the 20 that we're not reaching, and how are we really doing a good job to make sure that people understand the choices that they're making or maybe not making by default. So.
Thank you. A very kind introduction, and it's right back at you. Heather and I have learned a lot over these past 14 years and hope to continue that learning process as we go forward. I wanted to talk with you about, as you see from the title today, this is really a kind of a two-part talk about colorectal cancer screening, which many of you know a lot about already, and then transitioning to something that Heather mentioned earlier, something we call the RCaDES Initiative, which is broadening out and takes us what I think is into what I could say the beyond part of this talk. So I will try to go through, since we do need to finish up by 1, right? So we want to try to move along here. So let's make sure that. Okay, so I have no conflicts of interest. If anyone has any ideas as to how I could, please let me know. But Louis Pasteur has said a lot of very interesting things and did a lot of outstanding things relative to research. But I hearken to this quote of his, which speaks to what we're all trying to do is discover new things, but also amplifies that message that is good, but what is even greater is to move those things that we learn into practice. That is, from my point of view, and I would agree with Dr. Pasteur, that is our ultimate goal doing our work. What I want to share with you today are findings and things that we may have learned from 3 randomized trials, one of which was done here at Christiana Care, you'll see, and then focusing a little bit on what is commonly referred to as health learning systems or learning health systems, however you want to think about this concept, and what we can do in order to take advantage of opportunities to move our discoveries into practice. Colorectal cancer screening, there are a variety of tests in colorectal cancer screening, visual examinations, stool-based tests. Our research has focused on both colonoscopy and FIT, fecal immunochemical test, recommended tests. And when you think about colorectal cancer screening, there's a lot of work that's done in community outreach and education relative to colorectal cancer and other cancers. And people can put things on the TV, they can send things out, they can go to churches, they can do a lot of different things to try to send the message that colorectal cancer screening is something that is important to do for those individuals who are 50 to 75 years of age, according to guidelines. But I think the action is really within health systems, and especially in health systems that have networks of primary care practices. When we think about the goal, 80% goal, where does that come from? The American Cancer Society, the Colorectal Cancer Roundtable, and a lot of other organizations have come together to establish this goal of reaching an 80% screening rate in the population by 2018. Well, we're in 2018, and we're not there yet. So, long story short, the Colorectal Cancer Roundtable is now in the process of thinking about rebranding that campaign from 80% by 2018 to something new that gives us more time to try to reach that goal. But reaching that goal is not necessarily the only goal. That is to sustain that goal is really the work that needs to be done as well. So, in reach in primary care practices is an essential part of this process, trying to reach this goal. And if we can reach this goal, we can find adenomas, large adenomas that can be removed, which prevent the cancer, find early stage cancers and treat those. And, you know, if you do that, you can actually make a big difference in colorectal cancer mortality. What we also know is that we're not at that 80% goal. How do we get there? We can do in-reach to non-adherent patients in primary care practices. In any given practice or in a collection of practices, you can look at those individuals who are eligible for screening and compute a rate of what the screening adherence rate is in that system or in that practice. If you look at the national data, NHIS data, they tend to say, oh, we're at 65% screening rate nationally. Well, that's just not true. I mean, what I mean by that is those data and those figures are based on telephone surveys that continue to try to improve them, but they're based on telephone surveys that include not just screening colonoscopies and other screening tests, but diagnostic colonoscopies are rolled into that, which is not screening, and self-report, which we know is not necessarily completely accurate. So we are really, in reality, nationally, at about somewhere hovering around 50% screening rate. I say that based on looking at medical records data in health systems, not on telephone survey data. But so we have a ways to go. Part of what's happening, which is outstanding, is the work that's being done in health systems, in practices, to remind physicians to recommend colorectal cancer screening to their patients and to offer screening and to try to make sure that happens, along with every other thing, all the other things that have to happen in primary care. There's also an outreach component here that we should pay attention to, which I have focused a good deal of my effort on. Those non-adherent patients who don't routinely come into the practice. And there we have the opportunity to augment or add to that base rate. And if we just say 50% is the base rate of screening, most of that is in-reach screening of patients who come into the practice fairly regularly. Therefore, what our mission should be, at least my focus has been on trying to encourage outreach to the other 50% of non-adherent patients. So if this is the audience participation part, the one part of the audience participation part of this. If we're already at 50% screening, and we want to achieve the 80% screening, and we want to go after the 50% non-adherent, what rate of screening do we have to achieve in that segment of the population? This is not surprising. You're not alone. When I ask this question, it takes a little time. If we're at 50% and we know that we're targeting the other 50%, what's the screening rate we have to get in that other 50% to get to 80%? 60%, absolutely. So that's our target for the outreach effort. And here are some of those data that I alluded to earlier. And the 63% is what it is based on NHIS data. We had the great good fortune of developing a working relationship with Heather and others here at Christiana Care and obtaining NCI funding to do a study that focused on colorectal cancer screening outreach to those that segment of the population that hadn't been screened. Now, this is the general population. be talking a little bit about African Americans and Hispanics in a minute, but this is in the general population. And we completed a randomized trial with approaching 1,000 patients, randomized them to these 3 arms of the study. And the control group essentially received usual care. The standard mailed intervention was, I'll go back to this in a minute, essentially a combination of an FIT, stool blood test kit mailing, and instructions to schedule a colonoscopy. That was the mail intervention. Tailored navigation intervention, a navigator actually called patients who received those same materials and tried to move them forward through screening. One of the things we did, and we thought we were very clever, but it turns out we weren't quite so clever, but we'll get to that. We felt that if we are identifying those patients in Christianic care, primary care practices who are eligible for screening for outreach, and we did a baseline survey with them, we could ask them which of these tests they might be closer to doing, which would translate into which of these tests they would prefer. So we actually had this question on our baseline survey, and here's a patient who, when provided information about the tests, both tests, was asked, what was your decision stage? And we could see this patient actually had a stronger stage or a higher stage relative to colonoscopy. So this patient preferred colonoscopy in our thinking, and was actually pretty close to doing screening, had an overall screening decision stage of deciding to do. That comes from a precaution adoption process model, which we won't get into today, unless anyone has any questions about it. So the standard intervention is described here. You see the patient education piece, a reminder piece, and the tailored navigation had to do with this call, which a navigator called, tried to review the screening options, determining barriers to adherence. But what we did here was, for those patients who were closer to doing FIT, the stool blood test, that's the test we sent them. We only sent them that test. For the patients who were, like the patient in this example, closest to doing colonoscopy, we only sent them instructions on how to do the colonoscopy. For people who were equal, we sent them both things. So within this tailored navigation intervention group, there were like 3 little subgroups. And we thought we were very clever doing that. Well, here are our hypotheses. Not surprising with a study like this, you think that these would be the effects. And these are the actual effects. Control group, only about 12% of those non-adherent patients actually went forward to screen over the course of 12 months. 33%, so we had a much more robust effect by just mailing these materials, and we had more of an effect through the navigation content. One of the things I'll say here is that, and this goes to the cleverness aspect of our approach, when you look at this TNI group, and you looked at those folks to whom we mailed both tests, that subgroup, the screening rate approached 50%. It was lower in the other groups, lowest in the colonoscopy-only instructions group. So what was the target rate that we had to achieve in the 50% non-adherent? 60. Well, we're closer if we think about sending both tests to everybody and then navigation. We're getting there, getting closer, right? So that was the NCI-funded randomized trial. We then took these insights and wrote a grant application that was supported by the American Cancer Society. And again, in the context of these national data, current colorectal cancer screening rates, according to NHS data, are kind of comparable between whites and African Americans. Whites a little bit higher, 63 to 59, so close enough. And we were fortunate enough to get an ACCEL-funded study, randomized trial, using similar methods. We realized, we know if we do a usual care, screening rate's going to be low. So we really dropped the usual care arm and just had this TNI group versus the standard intervention group. Same kind of standard intervention approach, same tailored navigation intervention approach. But this study hadn't been done. We did it in the general population, and it seemed as though the intervention kind of worked a little bit better among the African American patients in Christianic care, but we didn't know how well it would work if we just did this study in an African American patient population. So with the Einstein Health Network in Philadelphia, urban population, we reprised the study without the control group in the African American patient population. And we just had this major hypothesis relative to behavioral outcome. And lo and behold, we found that if you just mail out the materials, you can get a bump of 24% screening rate among non-adherers. And you get actually exactly the same rate of screening by doing TNI in the African American patient population. Now, of course, there are a lot of differences. It's an urban, there are a lot of other things going on here, but it was striking. We found exactly the same level of screening by doing the tailored navigation intervention in this study, only included African American. The other really amazing thing was the screening rate in the subpopulation that received both tests was almost 50%. Duh, I mean, maybe it's not such a clever thing to only send people to tests that they say on a baseline survey they prefer. That's why I say we thought we were very clever, but so now we were fortunate again because of having really good people. Any of you who are doing research, the first thing you have to do is have a good idea. Second thing you have to do is surround yourself with really talented people. If you have both of those things going for you, your chances of success are good. Only have one, well, work on the other. So we know, according to national data, again, telephone survey data, which you can imagine are kind of problems in terms of getting people on the phone and getting accurate report and so on in the Hispanic population, relatively new population, and so on. Screening rates nationally are about 50%. We worked with Lehigh Valley Health Network on this randomized trial, which was funded by the Patient-Centered Outcomes Research Institute. And in the Hispanic population in Lehigh Valley, the actual screening rate, looking at medical records data, was about 30%. Not 50%, not 60%, 30% in the Hispanic patient population. So, if you have 70% non-adherers, you have 30% adherers, and you have 70% non-adherers, what screening rate do you have to get to in order to get to 80%? This is harder. This is a little bit harder. So 30%, you want to get 70%, you have 70% non-adherers. What screening rate do you have to get to if you wanted to get to this 80%? Well, you have to get 70+%. That's the you have to get 70%, 70+% screening rate, 71% in the 70% non-adherers. Add that to the 30%. That's where you can get to your 80%. Is anybody scared at this point? Okay, so we did a few things differently in this study. One is we convened a patient stakeholder advisory committee to really help us think deeply, and they were involved through the course of this 3-year trial. Helped us devise, develop the educational materials. They helped us think about recruitment. They helped us think. They were involved throughout the study. An outstanding patient stakeholder advisory committee. We didn't just do a focus group before and then did our study. They were engaged all along, gave us pointers and ideas along the way. One of which was patient navigation in the Hispanic population. We started talking about patient navigation. They said, what does that mean? There's not a real translatable concept of patient navigation in Hispanic culture. So we landed on, using guidance from this committee, a patient assistant, which made complete sense to them. Someone who is going to assist you to work with your primary care. So patient assistant was the term, rather than patient navigator. So that just a little insight into what they can do. So we had a similar design with 400 patients this time. And if you look at that second blue box on the bottom, you'll see that at the time of the navigation call, we would identify their preferred test and not just figure out what test they preferred, but also how likely they were to do that test. Having a preference doesn't mean that you're going to follow that preference or do it. So we learned a few things from our earlier work. And we had learned a few other things along the way in terms of how we might be able to not just clarify test preference, but also determine likelihood of performance of the test. We'll get into that in a little bit. And then develop a personalized plan based on these two pieces of information that would help the patient get through the test that they preferred and were likely to. So that was that intervention. And by the way, at the end, we sent this plan not just to the patient. These contacts were done by telephone, not in office. These were all outreach telephone contacts to the patient. We also sent the results of that screening plan to the practice, and then sent a follow-up report to the practice as well. So this is the tool that we used, and Heather will recognize this as a decision counseling program that we developed over the past 15 years at Jefferson. And we've used it in a number of contexts. But in this context, we use this tool and a script that we, with the navigator, help determine the preferred test, identify those things that were likely to influence adherence, non-adherence, identify these are just kind of the steps going through this kind of navigation process. And we wound up, the program itself generates a report that indicates how strongly the patient feels about option 1 versus option 2, in this case, doing a colonoscopy versus not doing the colonoscopy, this patient preferred colonoscopy. And provided information as to why the patient felt that way, and included a preference-based plan for going forward and doing testing. This is an online program, all in a box, so to speak. Can be navigators and counselors and so on can be trained. We're actually using it in the context of a lung cancer screening project now. But this program is something that we use in order to guide the navigator through this interaction with the patient, come up with a screening plan. Okay. The same program can be used to help patients go through any health decision, but we've just used it here for colorectal cancer screening. So, non-adherent population, 2-arm study, usual care mailing materials, TNI, decision supported navigation, now DE-CTR, receives the same mailed materials, but then goes through this really very personalized interaction, kind of clarified both test preference, likelihood of test preference, or test performance, and so on. And we found 78% of those patients screened in the DSNI group. We were mildly happy. we were very pleased, of course, with the result. And of course, we did a number of things in different ways. Here we added a few things, especially this issue of not just providing both tests, but also the process. We handled the test preference clarification process and likelihood process a little bit differently. And we had some excellent patient navigators who were working the project. But this gave us a little greater confidence to conclude that providing both FIT and colonoscopy options can include increased screening. Tailored navigation, remember the first 2 studies, that can also increase screening. But if you add this decision support, you have a combined intervention of decision support navigation with the mailings as part of an outreach strategy, you potentially could really make a difference in overall screening. And given the subgroups, the racial ethnic subgroups that we were working with, potentially you could really do a big job on disparities. So yet to be proven, but that we think that may be likely. Now, first part of the talk is almost over. We think we've learned some things. We believe that the DSNI, the decision support navigation intervention approach, is something that is now evidence-based. We have a number of studies, and I just showed you 3 randomized trials. We've done other trials that kind of led up to those when I was younger. And I was younger at one time. We did all of that and kind of came to that conclusion. But we know if we wanted to now take that step of moving what we've learned into practice, that's not going to be done in the context of a study, not going to be done in the context of a randomized trial. We need to have and think about infrastructure that would be necessary in order to make that happen. And now, implementation science and implementation science research is really, I think, the way we need to go and think about going in that direction. What we know, well, before I go here, Are there any questions about the studies? Please.
Hi, just a quick question about the navigators themselves. Was there any attempt to match on kind of racial, ethnic
Yes.
qualities? Okay,
Yes.
and or cultural training?
Not
beforehand?
in the Hispanic Care project, but in the Albert Einstein Health Project with the African American patient population. The navigator were African American.
Okay.
In the Hispanic population, the navigator was Hispanic.
And is that parceled out at all in the analyses? Like, I'm curious if there's sort of an impact or an effect sort of that piece alone.
The only place we'd be able to look at that in our own work is in the Hispanic Care system study and in the literature. And the literature and both places seem to suggest that although matching a navigator with the racial and ethnic background of the target population is helpful, but it isn't the active ingredient. The active ingredient is someone who's perceived of as acting on the basis or as an agent for the trusted primary care practice and practitioner and or health system, and someone who is competent and well informed, and someone who can listen, and someone who's empathetic. So those kinds of qualities are not certainly obviously restricted by race and ethnicity. So you have to have those things as going for you. And if you add in the racial ethnic matching, you can actually add more to that. I think that's the consensus from our own observation, our own research. And I can say in the Hispanic Care context where we had a non-ethnically racially matched navigator, we didn't see any difference in rates in terms of race and ethnicity. We didn't really see that and couldn't attribute any of that to the matching or lack of matching.
And when you utilized the advisory board, was there any ability for the advisory board to provide any cultural competency training or any feedback directly to the navigators?
The navigator was part of that committee, was actually integrated into that committee. So they didn't actually operate separate from that committee. They were part of it. So everything that we talked about in the meetings, we had 6 meetings each year in the study with that committee. They were part of that process. Any other questions, please?
I might have missed this, but the individuals who participated in the 3 trial, they all were already actively engaged in primary care.
Correct.
And that's how you.
Well, when you say actively engaged, it's a little bit of just a
Work.
clarification. They had made a visit to the primary care practice within the previous 2 years.
Okay.
So, and we did that, really to facilitate contact, because by doing that, we thought we would have a better likelihood of having the correct address and phone number and so on.
And did the primary care physician then make that were they involved in
No.
any of this? No, just okay.
No, we went directly to the health system and used centralized administrative data, EHR data, in order to actually identify target population. Yeah.
Do you know, for the patients who screen with a fit test, do you know whether if these fit tests were positive, what the percentage followed up on those?
So obviously we had, looking at the FIT, the stool blood test positivity rate, and if you look at the largest study of 900 patients, and we had about a 40% screening rate in that 35-40% screening rate overall in that population. Then within that population of folks, we had a smaller proportion screen, and then we had 3 to 5% screen positivity rate. So we have small numbers. What I'm saying, we have small numbers of patients who ultimately had a positive FIT and were eligible for follow-up. But on average, the follow-up rate in that small population, which was similar across all of the studies, was about 60%. 60% follow-up colonoscopy. So there's another place where we have work to do in terms of the follow-up of abnormal screening test results. Please.
One more question. Did you look to see if there were differences, like with respect to either barriers or demographic characters between those that did select the FIT versus the colonoscopy?
We did not do that. We have not done. Oh, actually, take that back. We did do that analysis in the context of the Hispanic Care data.
Okay.
We haven't published these data, but we actually didn't see any predictors
Okay.
of choice for one test over. We didn't see that. So, but I can say that the screening rate, or the overall screening rate was driven largely by the FIT numbers, not by the colonoscopy numbers. But what you found interestingly is when you did the navigation or decisions for the navigation intervention, you actually saw the rates of both tests rise.
Mm.
And there, you actually saw the rate of colonoscopy rise higher than FIT. The actual rate wasn't higher, but the proportion who did a colonoscopy, comparing the mailed test and the navigated test, more folks who were navigated colonoscopy. So, anything else? Okay, so beyond. Now we're talking about trying to move what we learned into practice. You've seen this, you've heard this 17-year. It takes a long time to move things that we learn into practice. And implementation science is promising or hoping to kind of guide us towards helping to kind of make this happen. And I won't read this to you. Kind of you know that the aim of this effort, the goal of this effort, is to try to reduce the gap between discovery and impact. And you are, I'm sure, perhaps fatigued with hearing the term triple aim, but you know, if we can, the idea is if we can improve, it says here, experience of care, if we can improve the engagement of patients in their care, we then have a shot at improving the overall quality of population health by having them involved in their care and making choices together with their physicians and other providers that are better than they would be if you didn't have the patients engaged, rather than kind of the old paternalistic approach. We want to amplify, in terms of this triple aim, the engagement of patients with their providers, with the system, with the healthcare team, so that we can actually make more informed decisions about health and thereby reduce costs. This triple aim should be pursued in the context of what are being called learning health systems. Support systems that support the integration of, you can read the rest, and improve quality, value, and innovation. This is now the goal. Every healthcare system in the country, I believe, wants to be called or call themselves or define themselves as a learning healthcare system. What are the components of those kinds of systems? Well, you have data analytics, people partnerships. You can, again, read all of the bullets and ultimately deliver valued outcomes. Now, many aspire to this goal, and there are a lot of things that get in the way. But at the end of the day, what we want to do, and you as a Value Institute are or will or must play a central role in this process of helping the healthcare system identify and characterize the problems, the pain points for the healthcare system, and integrating research evidence with staff experience to identify evidence-based or evidence-informed strategies, whether it's an intervention or a program that would help to address this problem. And then essentially, simply put, try to move that intervention into practice and do that not just with one thing like colon cancer screening, but think about this as the work you do. And you may, and probably do, already think that this is part of your mission as the Value Institute and should be. But again, how do you actually get there? How do you actually do that? We have also been successful in obtaining funding from the Patient-Centered Outcomes Research Institute to actually develop an approach to catalyzing the development of learning health systems. And this is something that we call the RCaDES Initiative, reducing cancer disparities by engaging stakeholders. And for any of you who are thinking about or planning to or involved in writing grant applications, spend a lot of time thinking about acronyms. It really makes a difference when people read your grant application. It's a really cool acronym. Oh, that might get you a couple of votes. It's just the acronym. So think about it. It does make a difference. So RCaDES Initiative, I was particularly happy with because when we had our annual conference, we had actually little tokens.
Oh, cute.
So we had arcades,
Arcades.
tokens to the arcades.
So that's for a certain age group and above.
Well,
You know, the arcade.
I actually
The
think,
arcade
I actually think
for
our
certain
older,
age
I think our older population actually liked it.
I bet.
Anyway, that's another story. So we embarked on this process with with Jefferson Health and Lehigh Valley Health Network in southeastern Pennsylvania, and we were guided and are guided, continue to be guided by a framework that brings together two models, two theory-based models, the interactive systems framework and collective impact. And again, I think you have these slides, you can kind of read this as we go along. But to make a long story short, we framed this model in such a way so as to think of this as a process of moving what we have learned, what we know, into practice. You look along the top, you have the synthesis, translation, adaptation, implementation, maintenance continuum. But you have to have something that's guiding that process. It just doesn't happen. I mean, this is the problem that we have in the United States right now, is that we kind of know as health systems that we should be doing this, but we kind of also think that somebody's going to do it. But maybe it's the payers, the passive approach, thinking that we're going to achieve these goals through a passive approach to try to move them into practice is folly. It's not going to happen. So I think we need to have a more directed, more active approach to this. And in our context, we've developed a coordinating team of leaders who come together to kind of organize this process. We've established a steering committee, which you look at that kind of oval at the top in the middle. We brought them together in order, and these represent most of the major payers in the southeastern Pennsylvania area, American Cancer Society and other organizations, community-based organizations in the steering committee. To help guide and leaders of the health system are all part of the steering committee. And we have this patient stakeholder advisory committee. Remember in the study, the randomized trial we realized that was a really good idea. So we brought that idea along and formed this patient stakeholder advisory committee, identified learning community champions such as primary care practitioners who can be part of this process. And now we have meetings. This learning community, it numbers between 80 and 100 people in these two health systems. And we interact with them in order to kind of move this process along. Communication is really key. We have a variety of ways in which we interact with our learning community through telephone, email, meetings, online collaborative software, and we try to pull everybody together so that we can not just communicate and interact and achieve things in silos, but try to move the process along together in this community. We have scheduled meetings with each of these groups, and we really try to move along with a common agenda. Each component, the coordinating team, the steering committee, the patient stakeholder advisory committees, they have their own agendas, but we as a learning community have a larger agenda that we're trying to pursue. And we know that this is going to take time. We just started this process in terms of over the past couple of years. We know there's a long future ahead of us in order to kind of make this work and function and be able to achieve and measure outcomes. But this is how we are proceeding. Specifically, there are things that we need to do in order to increase screening rates. And this project was focused on colorectal cancer screening and lung cancer screening. For those men and women who share, those are the two biggest cancers for men and women together. We felt that those were two targets that we wanted to achieve. So this learning community is assessing screening rates, interviewing intervention administrators, doing an assessment of organizational readiness to actually move evidence-based interventions into practice, looking at the kinds of evidence and the kinds of things that are actually being done, and looking at what the literature says so far as evidence-based interventions are concerned, so that we then identify an evidence-based strategy to move forward with. In terms of the different components, this patient stakeholder advisory committee is the actual engine that actually makes adaptation of the intervention happen. One intervention written one way or delivered one way doesn't necessarily make it. It has to be adapted so that it fits the needs of the population, any intervention approach. It also has to fit the practice and what's necessary You can't interrupt the workflow of the practices to kind of do this. So this patient and stakeholder advisory committee is really about the business of trying to make the interventions fit the populations and the practices and have high fidelity, meaning that we're not losing the active ingredients of the intervention that made it work. So, and we have a similar, that they went through and are going through a training program, so that these are just not folks off the street from the community telling us what they think. We're actually training them to do adaptation within the context of the health system. So this is an engine in the health system that is intended to drive change in the health system through by following this kind of curriculum. And what we're doing now that we have this system set up and now that the system is functioning, we are now pursuing this last component of this process of implementation and maintenance by pursuing research grant opportunities. This is, you may have heard about the Beau Biden Moonshot Awards. They had an award for colorectal cancer screening. We submitted an application to actually gain support for moving the DS&I into each of these healthcare systems. And we've actually added a third healthcare system, the Penn State Health System. So Penn State, Jefferson, and Lehigh Valley are collaborating on this application. So we hope to generate the source of support for actually achieving that last part of the process. I won't bore you with this. I'll just say that one of the other things we know is the electronic health record is here, and that there's some patients on the health record, and we potentially can use the portal to help deliver some of the interventions of those folks who are on the portal. But we're not putting all of our cards or all of our chips or all of our tokens on the EHR. We're kind of making sure that we deliver the intervention both inside and outside the EHR to this in an outreach fashion to patients. The other thing that we are doing, and we actually have just recently been funded, received about a $3 million grant from the BristolMyers Foundation. We're applying these same approaches, the same methods to increasing lung cancer screening in these healthcare systems. So this is just a quick snapshot of the nature of the lung cancer screening program that we are looking across each of the systems to catalyze and to make sure it work and to bring this apparatus, this learning community to bear on trying to make that happen. And you see in the middle of all that is this decision counseling program, which I talked about before, to facilitate shared decision making about lung cancer screening and smoking cessation. If you want to learn any more about the RCaDES Initiative, we had 2 conferences, and we have information about the RCaDES Initiative at our website, jefferson.edu/RCaDES. And there are some videos there. And if you want to think from a kind of cartoon fashion, what does all this mean? How does it all come together? How does it all make sense? We think you need to bring these players together, engage these players in this learning community in order to follow the road signs, so to speak, along the bottom, reaching implementation and ultimately disseminating the lessons that we learn, not just within a health system, not just across a health system, but potentially, if we do our work well, we may have a model or approach that we could use to accomplish these goals in any health system. What's our goal? To try to catalyze the development of learning health systems. Now we have it. Now we have a chance. Now we have an approach. Now we have a set of ideas. We have to continue to develop and refine them. But I think the possibilities are substantial for not just looking to literature and saying what should be, but trying to make that into what is and what will be for these health systems. So that's all I have to share with you today, other than my thanks and happy to answer questions.
What do you see as the sort of biggest barriers to, transitioning from what should be to what is in this?
So if I don't know what's there are many.
Yeah.
One of the barriers is communication. If you, let's say, for example, we want to integrate the decision counseling program or figure out how we can integrate the decision counseling program, which we're doing, into the EHR. We at Jefferson use Epic. Lehigh Valley also uses Epic. Penn State has Cerner. And I know you have Cerner. Well, this is a connecting the dots issue, right? And this is a silos kind of issue. who do you speak to in order to get the authority and resources internally to actually make that happen? So identifying the right person or persons to have that conversation and then moving that discussion through the process to getting the authority and the allocation of resources to actually make that happen. That's an example of a problem to try to do it. But if you don't have the people on your steering committee who can actually advise you, which is actually what the steering committee is really charged with the responsibility of helping us figure out how we actually make this happen within the health system. And then, so that's one issue. Well, another would be what we don't want to have happen is have, from a patient perspective, we don't want to have patients treated differently in terms of cancer screening, for example, or follow-up. If they happen to have Medicare versus Blue Cross Blue Shield versus Aetna versus, we don't want that. We want something more coherent, more cohesive. So we have on our steering committee all the major payers. So our plan and our process is to start this process by forming a working group that we call the Cancer Screening Implementation Group, CSI, the CSI working group.
Another.
So we have
We're coming to you for our
all right,
acronyms, as you see.
so forming that group and having them responsible for working with us and with health system to think about how we actually can address this problem of delivering care in a consistent way without surprising patients with co-pays and things like that. Relative to cancer screening, you can do that in relation to cancer screening. You can do it. So maybe this is a process. So that's another problem that we're thinking about and working. A third is whatever we do, we have to take into account the existing workflow, right? And the priorities of the teams that are already delivering care. And this takes me to a place where I think part of the answer, an important part of the answer, is the centralization of intervention delivery for the primary care practices, not asking the practice to do it all in their center. So a more centralized approach. So that's another. Sorry, it's a long-winded answer. Please.
I noticed that the last project that you mentioned,
The lung cancer screening one?
You mentioned that the implementation cost effective. I would like to know in what kind of 2 or 3 ends to estimate the cost and the effectiveness in
The end, you say the end or the outcomes, you mean? Or?
Yeah.
Well, the outcomes, obviously
words.
one of those outcomes is screening. Another is when screening takes place, there are things that are found, lung nodules are found. Those nodules have to be evaluated. So what are the costs associated with bringing people into screening? Then there are costs associated with following up the abnormal screening results. And then obviously lung cancer screening isn't just a singular event. There's a series of supposedly annual screening. So what are the costs associated with doing that? And if you look at kind of doing that without doing it in a systems context, what are the costs of doing that just as we're doing it now? And what are the redundancies? And what are the, many patients, we know that many patients who are diagnosed with lung nodules on the basis of screening don't come back for follow-up. Same problem with having an abnormal FIT result. Well, that's a problem. And what are the costs associated with that? What are the long-term costs associated? So those are some things we have to take into account when looking at issues related to cost by doing it in the usual way we do it, or do it in a more systematic, coherent fashion where we're actually making it more likely that people are going to go through screening in a proper, kind of well-organized fashion. So I don't know what the answer to that is yet. I'll come back in 4 years and later.
Thank you.
So I have just a question. If you, from a system thinking standpoint, when we talk about colorectal cancer, at least here versus lung, colorectal cancer is often one of our chosen quality measures / benchmarks. Lung is not, and it's
Right.
probably not going to be for a while because it is a sort of more defined population. Any sort of lessons learned, thoughts, advice, words of wisdom on how to approach maybe something that isn't quite as on everybody's radar?
This is where it's really important to engage both the healthcare system, the payers, and the providers in this discussion. Lung cancer screening is not a quality measure for primary care. Medicare is strongly promoting lung cancer screening. So the preliminary discussions that we've had with both leadership at Jefferson and Lehigh Valley and with the payers is that they want to improve lung cancer screening. They are not happy with the way it is currently being done or not done, and they want to improve that. So I don't have an answer as to. I think part of the answer is that if the system values it, lung cancer screening, then this I think would help to support the argument that a more centralized approach to lung cancer screening, supported by the system and figured out, and the strategies for supporting that, figuring that out with the payers and the system leaders, is probably the way to go. It's not going to be. It's going to be a process that is going to unfold. But as of right now, lung cancer screening rates across the country are below 5% for those who are eligible for lung cancer screening. So we as a health system, let's just say, for example, let's say we as a health system, Jefferson Health System says, well, you know what? We want to improve this situation. Let's start with smokers. Let's start with identifying all of the smokers in all of our primary care practices who are within the age parameters and otherwise qualify for lung cancer screening. And that's going to be our denominator. Now, let's talk with our payers about how we can actually approach this population, what we can offer, and how we can actually move them through the process of lung cancer screening. That's not taking the whole world on. That's taking a chunk, so to speak, of the problem and trying to figure out a way to actually work on that problem. Plenty of problems within that because of insurance and racial and ethnic differences and other things. But defining, in the context of this health system approach, bringing the players together to talk about a quote-unquote manageable aspect of the problem and figuring out a solution for that manageable aspect, I think is the starting point. And not allowing it to fall within the entire responsibility of the primary care physician practice, making that a system approach and a system solution for this subset of patients. This is how we're going to do it, boys and girls. This is how we're going to do it. And we want to make sure that we do this well, and then we can broaden it. So I think that's a more incremental approach might be the way this gets done. And by the way, along the way, I'm on the National Colorectal Cancer Roundtable and the National Lung Cancer Roundtable. And these questions are germane there. And at that level of discussion, there is talk about how we might be able to affect the HEDIS measures and others. So it's all kind of working its way through. So, yes, please.
With the RCaDES Initiative and then with the new initiative, how do you gather the data? I mean, how do you know that the screening is improving?
So what we're doing now, so first of all, BristolMyers Foundation has funded a number of different projects around the country. There's a project at Mayo, there's a project in Kentucky, there's a project in Maine, and we just had a meeting a week ago, where all of the players, all the funded parties came together, and I obtained agreement from those 3 other sites to share their materials, put together an inventory of their materials, an inventory of their data repositories and how they're collecting data and instruments. So we're actually pulling all of that knowledge together with them. Now, in the context of the system that we're working in now at Jefferson, we are now working with our quote-unquote enterprise analytics team at Jefferson to actually do what I just described. Identify the smokers, look at the screening rates, and find the algorithm that we can use on a repetitive fashion in that population. So we will be able to identify what the low-dose CT rate is, lung cancer screening rate, for that defined denominator in 2016. We'll be able to look at it in 2017, 18, and so on, using the same algorithm. So we'll be able to see, and then, by the way, we'll also have primary care practice in that database. So we'll actually be able to see whether the rates that are in the lower level practices, they're all low, but we'll be able to see at a practice level whether the rates are also changing. And we'll be able to look to see how the delivery of our intervention approach, where that's going. So it's not a randomized trial, but it's a kind of pre-post kind of baseline, and then we'll be able to see whether the delivery of the intervention, where it's being delivered, and where those rates are changing.
And so it's, I mean, your rates are based on electronic health records that are all for the cancer RCaDES Initiative also.
Correct. Correct. That's correct.
Do you have the payers also? I mean, can you get the claims from the payers or?
Well, what we're looking at are essentially billing for low-dose CT codes for that. So we can look at our own data. There is also an organization within each health system you can actually generate. Every health system has those kinds of data, some more cleaner than others, but every health system has those data. There's also an organization called HSX in Philadelphia that's trying to pull all of these payers databases together as well. Kind of a longer term effort, but something that we need to kind of, they're going to be on our steering committee as well to kind of make sure that they're represented in this discussion so that they can help us think through how this gets done. So we just started in February, but I think we have some good thoughts and good ideas and plans to bring these things together in order not just to figure out what we can do, but how we can do it, deliver it in such a way so as to meet the needs of a high-risk population within the African American and Asian American patient population in Philadelphia that are served by the Jefferson Health System. That's where we're at.
We can't wait.
Yeah.
So 5 years from now?
Well, it's we need to learn a lot. We've learned some, and now, but you know, the thing that I'm hopeful about is that we have a well-defined and well-articulated model, and those components make sense, and we have buy-in from a lot of people who are in the right place, the right position, with the right authority and so on to try to make this happen. So I think the odds are in our favor, but no guarantees. But as we go forward, I'm really happy and excited to be part of this process as we learn, not just at Jefferson, but again, we're learning within the context of this larger Bristol-Myers Squibb funded consortium of sites, and we want to share what we've learned beyond that. So I think there's a real opportunity here to not just make a difference in our own backyard, but potentially frame the development of a model that could be applied anywhere. That's the exciting part for me.
That's very exciting.
Can I ask one more question? Are we?
Oh, please go
Are you
ahead.
okay?
I'm sorry we're running.
Do you have a sense of whether or not the model that you have would be applicable to more than one behavior at a time?
Absolutely. There's no question about it that the model is intended to be a generic framework, generic model. That if there is an issue of pain point for the system, and there is an evidence-based approach to addressing that, this model can apply to any health problem where there is a well-defined solution. Remember, it involves not just applying the intervention, but adapting it so that it actually fits the population of practice, so that then we can work on not just adaptation, but ultimately implementation and maintenance. So it's a process for any intervention approach any evidence-based intervention or program that you would ideally want to apply. But I think it is generic, and if we think that at some level, there's always going to be some aspect of this that requires decision support and navigation, then we actually have a software program that actually fits right in the center of that process. That could actually, and that DCP, the Decision Counseling Program itself, is a generic program that can be applied to any health decision. So I think we have a couple of other things there. But we'll see.
Thank you.
All right. Thank you very much.